Predictive genomics is a somewhat emerging field where it's really combining a couple of different areas of science and technology. It's where we are trying to pull together information that we know about a person's genetic background, or in this case, the genetic makeup of their cancer, and then applying some bioinformatics and learning algorithms to that information to make predictions about what's going to happen in the future. In breast cancer, this is most relevant today in the setting of low-stage breast cancer. There are several tests on the clinical market right now that provide additional information after a woman has undergone a surgical resection of a breast cancer tumor that analyzes the cancer cells themselves to give more information about whether or not that person would benefit from additional chemotherapy or further treatment after surgery to reduce the risk of cancer coming back. Yeah, so there's sort of two key places to think about genetic mutations in breast cancer. One is what we call germline or inherited predisposition syndromes that increase the risk of developing breast cancer. So these are, again, the commonly thought of BRCA1 and 2, other hereditary cancer genes that increase the risk of developing breast cancer. We know that if you carry those mutations, your lifetime risk is higher than someone who doesn't carry those mutations. That, though, doesn't necessarily define how your breast cancer will behave. So the fact that you carry a BRCA mutation doesn't tell us if your breast cancer itself is going to be more aggressive or less aggressive, harder to treat or easier to treat. There's other genetic mutations that happen within breast cancer cells that are not related to whether or not you have a germline predisposition. The simplest way that I think about this is every cell in our body has signals inside of it that tell it when to grow and when to stop growing. An incredibly tightly regulated process from the beginning of time. Cancer happens when something changes inside the genes of a cell, and signals that tell that cell to keep growing and dividing get turned on, and signals that tell it to stop get lost. So genetics and genomics are incredibly valuable to understand what specific changes are happening within a cell that are making that particular cancer cell grow. And that's where in breast cancer, there's, again, the risk that just says, are you at increased risk for developing breast cancer? That's the BRCA hereditary mutations. But then regardless of whether or not you have those hereditary mutations, it's important to learn more about what specific changes inside someone's cancer cell are driving growth so that we can fit treatments most appropriately to that person's individual cancer. To get into a little bit more detail of the kind of use case scenario in breast cancer for predictive genomics, like I mentioned earlier, the thing we know the most about is an early stage breast cancer. So women who have a relatively small primary tumor and where the tumor has not spread into the lymph nodes or has only spread a very, very small amount into the lymph nodes. The current treatment paradigm for those women is typically to do a surgery to remove the tumor from the breast, to use then we look at the breast tissue underneath the microscope. And for women who have estrogen receptor positive breast cancer, the standard of care is to give a hormone therapy for a number of years afterwards to decrease the risk of cancer coming back. We also know that some women, their cancer will never come back, and some women, their cancer will definitely come back. So chemotherapy, which is just a general class of medicines that kills cells that are growing and dividing more quickly, can also be used to try and catch, again, those microscopic amounts of cancer cells that are still left in the body after surgery or are not taken care of by endocrine therapy. What we've learned is that some people really need chemotherapy and other people don't need it at all. And so where predictive genomics has really come into play for breast cancer is better defining those two populations. Which group of patients with low stage breast cancer are going to do better if they get that chemotherapy, and which group of patients don't need it. So the way that this testing works is that after someone has had their tumor removed by surgery, a sample of that tumor is sent off for a special test. And that test is looking at a panel of genes within the breast cancer cell itself. And there are combinations of changes in those genes or expression patterns, how much certain gene products are being made and used within the cancer cell, that tell us whether or not adding chemotherapy to someone's treatment plan is likely to reduce the risk of cancer coming back. So it's a huge advantage in that it is allowing us to have more information to right-size cancer treatment. We can not give very toxic chemotherapy, so medicines that can cause a lot of short and long-term problems for women, to women who are very unlikely to benefit from it. And we can make sure to only use that in women where we think without it, their risk of having their cancer come back is significantly higher. So it's critical to use it in the scenarios that we've studied. So whenever there's a new test that comes out, there's always excitement and wanting to extend the use further. So one of the key limitations is we only know that this type of testing is really beneficial in a very narrow window of patients. Women with low stage breast cancer that's estrogen receptor positive, that has 0 to very small amount of lymph node involvement. One of the limitations is that that's only helping those group of people. So people want to sometimes use these tests and extrapolate into more scenarios, but we don't have the research that supports that type of decision making right now. Another limitation is that it's only one piece of data. So overall decision planning and treatment recommendations need to combine a lot of different pieces of information. This genomic information can help doctors guide you to choices as a patient, but they shouldn't be 100% based on that information because it's just too limited to be able to be sort of the all or nothing decision for treatment. I think the biggest tangible improvement we've seen is sparing people chemotherapy who aren't going to benefit from it. So what it has done is it has allowed people to not be exposed to toxicity with very limited benefit. And of course, the short-term side effects that people think of with chemotherapy are great to avoid, such as feeling sick to your stomach, vomiting, hair loss. Those are all relatively transient. There are less commonly understood, but really significant side effects that are also being avoided. A number of these medications are cardiotoxic. They damage the heart muscle over time. So receiving them can put you into early heart failure and make you at risk for more significant complications. There are implications to bone health and kidney health from getting chemotherapy. So the ability to avoid chemotherapy in patients who aren't going to benefit from it is far more than the short-term benefit of not feeling so sick from the medications. It's really saving that long-term organ toxicity to keep women healthier longer and minimize the impact that their cancer diagnosis has on their overall health. I think the hope is that we find more ways to use this type of information, meaning that we can expand outside of those limited scenarios I described right now, where we can better understand how to connect the right treatment to the right patient and have it make sense across the whole treatment profile. So that is my biggest hope, that we learn more and that we can not only say, is chemotherapy helpful, yes or no, but that we can get more information about which chemotherapy or how much chemotherapy or who should get radiation added in and who shouldn't. Again, so that we can continue to right-size treatment, give people who need what they need and nothing more and nothing less.